Hello, I'm Dr. Joynita Nicholson, a board certified obesity medicine and family medicine expert who also has been a pioneer in my community in Richmond, Virginia. I am here with Nick Pennings, the chair and associate professor of family medicine at Campbell University School of Osteopathic Medicine. He is board certified in family medicine and obesity medicine with a fellowship designation in both. Oh, Nick, I am so pleased to be here and discuss these topics with you today. We are going to review a comprehensive approach to obesity management. And the first question I want to ask you is what are the Obesity Medicine Association's four pillars of clinical treatment?
Well, it's a pleasure to be here with you today, Dr. Nicholson, and I'm always happy to talk about this topic. And I really like that four pillars concept. I think it provides a really great framework for treating obesity. So the four pillars are nutritional therapy, which is focusing on dietary interventions and nutritional interventions, physical activity, which is a very important component, and these are kind of core lifestyle components of obesity treatment. And another core component of obesity treatment is behavioral modification, which really addresses the why we eat, and that is an often overlooked component of obesity treatment. And the last is medical therapy, which is a combination of medications and intervention procedures, either endoscopic procedure, bariatric procedures. So it's important to recognize that obesity is a complex disease, and so there's a wide range of contributing factors, and each one of these pillars plays a role in the management of obesity and to varying degrees. And it's important to be able to tailor your therapy to your patient. The challenge is many clinicians just don't know where to begin. It is such a complex, comprehensive disease that is challenging, and so clinicians need to kind of know where to begin. And when I work with my students and residents, I find the four pillars as providing a very easy framework for them to work in, to be able to develop a strategy for treating obesity so that they can develop a nutritional strategy, an activity strategy, a behavioral strategy, a medication strategy, and consider bariatric surgery where appropriate.
Nick, these four pillars also remind us that treating our patients with obesity is more than just telling them, put that fork down, push back from the table, move more, eat less. You know, that concept we were talking about that started in the 1930s and still here almost a century later, some clinicians still tell their patients, it's a reminder that no, it's so much more than just the nutritional and the physical activity component. But we also need to take time to address the behavioral as well as know that medications and surgical interventions are available. So yes, I am so glad that you're starting it at least with your medical students, because as I stated in the previous podcast, many medical school institutions do not have this type of education available yet. But we are hopeful as we move forward that we will continue to try to make that a priority as well.
So this is a passion of mine, and I think that's where we need to continue to strive. So Dr. Nicholson, perhaps you can do a little deeper dive on how each of these pillars contribute to obesity management, and what's the evidence behind their effectiveness?
Yeah, the first pillar is nutritional therapy. Or another way of thinking about this is our dietary counseling with the patient. Now, this is the most important component of the treatment plan for obesity. And in order to create a sustainable dietary pattern for weight loss, patients need to be able to make changes that manage their energy intake while receiving optimal nutrition, controlling their hunger, and promoting their fullness or satiety. And for weight loss patients, we need to be able to encourage them to regularly make simple, healthy shifts within their habitual eating pattern so that a reduction in dietary energy density leads to that lower energy intake. Simply said, we need to limit those simple sugars in the diet and the sugar sweetened beverages and the unhealthy foods such as the refined grains and sweets and processed foods, trans fats, while choosing healthy, nutrient rich foods and drinking water in the right amounts and at the right times. The next pillar is physical activity. And with this, it's very important to know that it's a physical activity alone is not going to help patients lose weight, but when we use it in conjunction with the nutritional counseling, we can have an even more robust effect on weight loss and overall health. And physical activity isn't just aerobic. I think when people think of physical activity, they think of, just when they think of moving more, they think of running and walking and jogging. And yes, all those things are wonderful. But when you're dealing with patients with obesity, you have to meet them where they are. Everybody's not going to be ready to run for 30 minutes straight, 5 days a week, which is the current recommendation for a healthy type of intervention. But if they can get up and move for 5 minutes, right, at a time, and then do that multiple times in their day, there's some studies that do support that even if you don't do, or actually if you don't do the full 30 minutes straight, but you break it down into smaller segments, that this is an even richer approach to weight loss and weight substitution. So when we think of physical activity, I think of it as ABS. How appropriate, right? ABS. So the A is aerobic, and that's 5 days a week, 30 minutes a day is the goal. And that includes things like walking and running and swimming and that type of thing. When we think of the B, that is more of balance. So with that can be more of like your Tai Chi, your yoga, that even Qigong. I think some people are involved in that. The first S is stretching, which we should do even upon awaking in the morning, just for about a minute stretch, and then maybe stretch again right before bedtime. But it is important to try to stretch as well when you are engaged in active aerobic activity and the balance activities we were talking about. And then the final S is strengthening. And with strengthening, that's really important because when people are losing weight, they oftentimes are also losing some lean muscle mass. And the other component of that is when patients are over 65, and we oftentimes don't think about this, or when patients have gone through menopause or andropause, we tend to have a reduction in those hormones, which can contribute to a decrease in our muscle mass. So we need to have a way to maintain the body's muscle mass as we lose the weight and get to healthier states. And we usually do this by encouraging at least 2 days a week, having some resistance exercises so that we can continue to strengthen and keep our muscles nice and toned. So one of the primary benefits of physical activity is to improve the cardiorespiratory fitness, preserve lean muscle body mass, reduce total abdominal fat and visceral fat, improve sleep, as well as reduce obesity-related cardiovascular health risks. And as we do this, we will also enhance a sense of well-being independent of the weight or body mass index. When we are creating our exercise prescriptions for patients, as clinicians, if we use what the American College of Sports Medicine recommends, we do want to encourage that there's a minimum of 150 minutes of moderate intensity physical activity per week as the first goal. The dietary guidelines for Americans found compelling evidence that at least 60 to 90 minutes, which is about 7 to 10 and a half hours per week of daily moderate physical activity, that this is needed to sustain the weight loss. And they also recommend, as we stated, that we have the resistance exercise component 2 days a week with the other types that we mentioned. So when we're making our actual prescription for patients, we want it to be what we refer to as the FITT principle, F-I-T-T-E. The first letter F is for frequency. I is intensity. T is timing. The next T is type of activity. And then the E is we want them to be able to safely enjoy the activity. So if a patient is not enjoying their physical activity, guess what? They're not going to do it. No. So Nick, it is so super important. And I read an article that you participated in recently, and I love how even in that article, you all were emphasizing how just turning the radio on and dancing for 5 minutes during lunchtime can really help the body move, and we can reap some of the benefits that are needed for this cardiovascular improvement.
Make it fun.
Yes, kudos to you. So when we're talking about behavioral therapy, we have to go back to not just the stress management, not just the mental health. Those things are important, but it's those things right? It's the other things that either contribute to a person having weight gain or excess weight or just not feeling their best, or it's those behaviors that keep the patient from having their weight loss success or achieving their health goals. And so that includes things like their use of caffeine, which can also interfere with sleep, which is another part of behavioral health. If patients are consuming too much caffeine or consuming it too late in the day, then it certainly can interfere with their REM sleep, which in turn, we know if a patient is not getting the 7 to 9 hours of sleep at night, it is going to contribute to a hormone called ghrelin being released into the bloodstream. And ghrelin's coming from the stomach. And we think of ghrelin as it's that hormone that makes the belly growl. You just can't feel full the next day, and it does contribute to weight gain. So when we are able to get those 7 to 9 hours of sleep, we then can turn off that release of that ghrelin in excess, and we trigger more of a release of a hormone from the fat cells called leptin. And with the release of the leptin, we're able to feel full better the next day. So it does contribute to that. And nobody really realizes how important sleep is. So that is an eye-opener for me when I do share with patients how important those 7 to 9 hours of sleep are, because many people are staying awake later at night to work, or I've had some people say, I put the kids to bed and then I stay up because I need some me time. And they had no idea that staying up so late was actually harming their health. So sleep hygiene is one. The substance use, but also when we're thinking of the lifestyle modifications, we want to make sure if there are any eating disorders that we stabilize the mental health disorders before moving on to the next pillar, which is medication use. So let's look at pharmacotherapy. That is the fourth pillar. And this should be considered only if the patient will be utilizing this in conjunction with the nutritional and the physical activity components. All of those things are needed for a weight management program to be successful and for our patients to receive their optimal successes. So appropriate patients must be chosen for the appropriate medications. I'll give you an example. If you know a patient is consuming a lot of caffeine, let's go back to that, and so they are not sleeping the best at night, then a medication such as the phentermine or the phendimetrazine or the diethylpropion may not be the best option for that patient until we stabilize that sleep component and better address that substance use of caffeine. So, again, it's important to take that wonderful history so we can understand where the patients are and then choose an appropriate medication. It's important as well when we think of pharmacotherapy, not to just think of what it is that we would use to treat the patient, but also look at the medication list and review what the patients are actively taking. Because if they are taking medications that can contribute to weight gain, then we wouldn't just stop them abruptly, but certainly we'd like to start having those conversations with them to identify those medications and to consider more weight neutral or weight negative medications, but have them maybe even to follow up with the prescribing doctor. I wouldn't just abruptly stop them because you'll make a lot of enemies in the medical community, but certainly this offers opportunity for those conversations to start to happen with those entities and give the patient some responsibility. Tell them when they follow up with their prescribing doctor to let them know, look, I'm really working on my weight, and my other doctor has shared that this medicine is contributing to weight gain, and if there's anything else that we can prescribe that would not have that side effect, if we can start that would be wonderful, because I want to feel better, I want to be the best I can be, and I want you to be a part of that journey. So Nick, can you discuss the importance of a multidisciplinary team approach in the management of obesity, and what roles do different healthcare professionals play on that team?
Well, thanks, Dr. Nicholson. I think that was a great review of all the four pillars and really an in-depth discussion of the components of those. But I'm sure there's a lot of primary care providers listening to this saying, how do I do all that? That seems like a lot to handle in a 15-minute or less visit. And so I think that speaks to both some of the strengths and the limitations of the four pillars model. The strength is it creates a very simple framework to follow, and that makes it easy to kind of structure a plan around. But the limitations are it's a lot to deal with. And so how can you work within a multidisciplinary approach to be able to address those four pillars? As you mentioned, nutrition is a key pillar. But nutritional training in medical school is limited, and very often it's really the nutritional education that you've gotten outside of medical school that becomes the source of your advice and evidence. So there's where we can tap into registered dietitians that can help, and I work with a registered dietitian in my practice, and I find her very helpful for being able to come up with plans and working with our patients and holding patients accountable for their nutritional decisions. And also, you need to be able to tailor that to the individual, and the dietitians can help with that. Physical activity is very important. Training in this field is also limited. We don't really get a lot of education on exercise. And this is where physical therapists or personal trainers that have experience in working with patients with obesity can be very helpful. As you talked about, behavioral modification is really an essential part of obesity treatment. But again, behavioral therapy can be limited and time-consuming. So working with psychologists or certified social workers with experience in treating obesity can be very helpful. Your pharmacist can be very helpful. They can help you with identifying alternatives to weight-promoting medications. And as you mentioned, I think it's really important to work with other prescribers that are prescribing those weight-promoting medications to make appropriate changes. The last point I really would want to make is that you want to either treat or refer a patient. There are obesity medicine specialists out there. We are specifically trained to treat patients with obesity and dedicate our practice to that. And so you want to refer where situations where you're not comfortable treating. But I also hope that more and more family physicians, other primary care providers, feel comfortable treating obesity. It is a chronic disease, and I see this similar to where we were with the treatment of depression 30 years ago. At that time, treatment options were pretty limited. The medications were not very effective. They had lots of side effects, and they typically were prescribed by psychiatrists. Well, fast forward to today, we have great medications that are very effective and very well tolerated, and most of depression and anxiety is treated in primary care. So my hope is that we develop this continuum of care where the primary care provider is first line in treating obesity, and the more complicated cases are referred to an obesity medicine specialist, and then those more complicated cases go on to bariatric surgery.
Well said, Nick. And what I love about what you shared is it's very much specific for primary care doctors to understand our important role in identifying these patients early on so that we can contribute and intervene to helping them improve not just their weight. It's not just about improving a weight or a body mass index. It's about helping them improve their overall health, their medical conditions, their sense of well-being, their confidence. All of those things get better when we start to see that 5 to 10% weight loss or improvement of the body mass index by 2 units. And we're going to get into, and I love the next question, so stay tuned, listeners. We're going to get into a little bit more about the resources that are available for patients as well as for the clinicians. But I did want to comment, when we are trying to find that time, Nick, to address obesity, one of the approaches that I've found helpful is because you want to use tools like motivational interviewing and make sure that the patient is ready for this discussion. But some people don't know they have a disease. They really think because other people in their immediate household or culture resemble them that they are healthy. And they don't know until they come in to see the doctor that, at least according to the body mass index, which we know has its limitations, it does. And so we shouldn't just limit our discussions to the body mass index, but if we're able, look at the waist circumference, look at the percent body fat. Look at the neck circumference, and look at all these things in addition to the patient's medical conditions and their overall health to start to have discussions about where their starting point is. And then we can build what we believe is going to be an effective plan for them. But I wanted to share, I use the body mass index as a vital sign. A lot of people have electronic medical records now. So if you do, I invite you to utilize it. Let it calculate your BMI for you. And then that way you can use it as a vital sign and start to let them know that based upon the body mass index, perhaps they fall into the category of obesity class 1 or class 2 or class 3, or maybe they're overweight. And then you can start to talk about what this means and what you all can do to improve it. So just wanted to give you a little pearl that has seemed to help me through the years.
So it is a complex disease, and patients need support through that process. So how can patient support networks contribute to the long-term planning for sustained weight management?
Nick, there are so many options that patients see when they look online, when they see billboards, when they hear commercials on the TVs and the radios. It actually becomes overwhelming and can become a barrier for some patients. But I'm so thrilled that we're performing this podcast so that we can help patients to understand that there is Calvary available, right? They can talk to their primary care physicians, they can talk to their specialists, they can talk to obesity medicine specialists, because we now are more knowledgeable about how to help patients with obesity. It is a chronic, relapsing neuroendocrine and behavioral disease, and it requires a multidisciplinary approach. And in order for patients to feel like they are connecting well, that they have a sense of support and accountability and information and encouragement, we have a community of network that is available to them, and it will help them to feel supported and strengthened and motivated and knowledgeable along their way in pursuit of better health. So when we look at healthcare professionals, that's where I'll start. That's their primary care doctors, that's their specialists, that's their counselors, their personal trainers, exercise physiologists. It's the people who have been trained to give them the support they need. But then we do have online and in-person resources in the community, like Overeaters Anonymous, or OA, and that's specific for patients who might have obesity, anorexia, or bulimia. There are different organizations. The one that's most patient-centered is the Obesity Action Coalition. And you join that one for a very minimal fee of $25 a year. And they'll send you journals, they have conferences, they have Facebook, they have IG, Twitter. So many wonderful ways to learn more about obesity and to feel supported. And they have a strong advocacy. There's the STOP, or the Strategies to Overcome and Prevent Obesity Alliance. There's the Obesity Medicine Association, the American Society for Metabolic and Bariatric Surgery, that they offer patient education tools. The Rudd Center aims to address weight bias. The next category is commercial weight loss programs, and they're changing as we're learning more information about weight management. And that's WW, or it used to be known as Weight Watchers. Noom, which I was going to comment, is actually a digital behavioral health support system available to patients. Jenny Craig, Medi weight loss programs are all available. We have gyms and boot camps and personal trainers. We have health clubs. We have dance studios. So there's a lot of support, especially for this nutritional and physical activity component. And if you want, you can even now purchase your own digital devices, such as the bicycles, they're exercise bikes, and some of them offer programs that can be very supportive to patients. They're treadmills, they're indoor cycling classes, they're stream live and sometimes on demand. There are numerous weight loss apps like MyFitnessPal, MyNet Diary, Lose It. So many more. There are meal delivery services, because some patients don't know how to cook, or maybe they don't know how to cook healthy meals because culturally they were taught to cook, eat more of the meat and the gravy with the rice. So you do have meal delivery services that are optioned to provide healthy meal app options, and they are pre-made and they're delivered fresh and they're quality ingredients. So this has been very helpful. There are also book clubs, and patients can not only read and utilize these self-help weight management options, but they can, ask questions to one another and just be a support in the book clubs. And now we do have inpatient hospitalization that's offered for patients with eating disorders in some communities. So this is just a little tap. I know that there's so many more, but I encourage you, when you're choosing resources and sources in the community, be selective. Everything out there is not good for you. So do your research and make sure that it is a research that is scientifically sound.
And I would agree. You really need to be able to vet those resources, because there's lots of great ones out there, but there's also some that are not so great. So you have to be careful in what you choose, and make sure you choose wisely, and work with your healthcare professional and making sure it's right for you, especially if you have other underlying health conditions.
Yeah. So, Nick, what are some resources? We just talked about the resources that were available for the patients. Now, if you'll share, what do our clinicians have? Who do our clinicians have as resources that they may not know about?
And there's lots of great resources out there. But the first, just to mention, as I said before, there are obesity medicine specialists that can help you, that are trained to treat obesity. But, we really hope that this becomes a bigger and bigger part of primary care. And I hope that these 3 podcasts with myself and Dr. Nicholson, that are being offered by Pri-Med, will be a good source of information. And Pri-Med offers a whole bunch of additional continuing medical education resources on obesity management, either through their website and recorded lectures, as well as live conferences. You can check out their live in-person conferences in 2024, and they're hosting a series of hands-on workshops with motivational interviewing that I was involved in helping to design. And so I think these are really helpful to improve some of the skills, again, that you're not taught in medical school. The other additional resources include the Obesity Medicine Association. There's the Obesity Algorithm, which is a great kind of easy to review summary of the treatment of obesity. And it goes through in a very systematic way. It goes through the 4 pillars, goes through a lot of the different components of obesity treatment. The Obesity Pillars Journal is a free open access journal on obesity medicine, and they have clinical practice statements that are very helpful for specific disease processes and specific components of obesity. Obesity conferences, the OMA has an annual conference every year that'll be coming in April. They also host the Obesity Fundamentals course, which gives you a nice introduction to obesity medicine. They host a review course for those that are preparing for the obesity boards. We have podcasts, webinars. There's the OMA Academy, which has a treasure trove of all the lectures that have been done at the obesity medicine conferences. So those are all components, and they also have a directory where you can find obesity medicine specialists. There's also the Obesity Society, another obesity medicine organization that's really focused on advancing obesity research. And they host conferences and grand rounds that you can sign up for. They also have a journal, the Obesity Journal, which is a fantastic resource for the latest information on obesity medicine, and as well as some on-demand educational materials. There's a host of other courses that you can take as well, especially if you're preparing to take the boards. Harvard hosts a Blackburn course in obesity medicine. The Columbia Cornell has an obesity medicine review course. And many now national and regional society conferences are including obesity content in their educational programming. So I think look for those and look to advance your education. There's a lot of great resources out there. So, Dr. Nicholson, let me ask you, what communication strategies can primary care clinicians use to support a more holistic and comprehensive approach to obesity treatment?
Well, Nick, when discussing weight with their patients, primary care clinicians must listen to their patients and communicate a compassionate and empathetic manner using patient first language, both verbally, and it's important to use it when we're documenting their encounter. And we must make sure that our staff has been trained and utilizing patient first language. We must make sure that our office furniture, equipment, and supplies can accommodate this group. And it is important to make patients with obesity feel welcomed, accepted, and important so they can actually hear and be involved and motivated and receptive to the plans we make together. A comprehensive obesity treatment plan should be built in an active, unbiased, patient-centered manner using the 4 OMA pillars as framework as well as motivational interviewing as a tool. And Nick, how can primary care clinicians effectively tailor treatment plans based on individual patients' needs and preferences within the 4 pillars framework?
So you did a great job at summarizing each of those 4 pillars, and I think it's important for clinicians to really think in terms of those 4 pillars when they're coming up with a plan. But we also want that approach to be very patient-centered. So when you're developing a nutritional plan, you, as a clinician, you should try to develop different dietary treatment options for your patients because you want to make sure it's geared towards that patient's needs. It's not very practical to recommend a plant-based diet for somebody who doesn't like vegetables at all. And likewise, it's not very practical to recommend a ketogenic diet in somebody that is a vegan. That's very hard to meet those needs. So you want to meet the patients where they're at and be able to develop a plan that meets their individual needs. For physical activity, I would encourage you to learn to write an exercise prescription as you outlined with that FIT model. This is something that I do with my patients. The OMA has a exercise prescription. American College of Sports Medicine has one as well. And I do this in a patient-centered way. I'll ask the patient, are you interested in increasing your physical activity? If so, what type of exercise will you like to do? How long will you do it for? What intensity will you do it at? How many times a day of the week will you do it? What days of the week will you do it? And again, what can you do to make it fun? And when I ask those questions, I write their answers down and then I hand them a prescription. And so this is a way of having the patient tell you what they're going to do, because I find when they tell you what they're going to do, they're more likely to do it. And then from a behavioral approach, remember to use people-first language. That's patients with obesity, not obese patients. Those kind of terms are not well received by patients and tend to upset patients. We want our approaches to treatment of obesity to recognize the challenges of weight loss. We want to be empathetic. We want to be supportive. We want to take that patient-centered approach. And so learn about motivational interviewing. It's a very powerful tool for being able to treat obesity. And then also learn about some of the cognitive behavioral therapies that are used for obesity treatment. And when it comes to medication, we want to, as you mentioned, avoid those weight-promoting medications and then become familiar and comfortable with anti-obesity medications. Understand when they should be prescribed and when they shouldn't be prescribed. And we'll talk more about that in the next podcast. And then also with bariatric surgery, know the indications and get to know your local bariatric surgeons. Those are some of the key players that you're going to want to know and work with to treat your patients with obesity. And so before we finish, Dr. Nicholson, do you have any key takeaways for our listeners?
Yes, I want to just reflect a little bit on some of the wonderful information you shared, Dr. Pennings, and share with listeners that even now, when we're thinking of dietary support for primary care clinicians, we also have other options like health coaches. They've been very helpful, and nutritionists. We now do have more online support, and there are more and more virtual physicians that are becoming available. But again, I encourage you to do your research and make sure that they're board certified and that they're given scientific information, scientifically sound guidance there. I did want to also mention that when we were talking about pediatric population, you made reference to the obesity algorithm. We do have not only the adult obesity algorithm with the Obesity Medicine Association, but there is one for the pediatrics population as well. So a lot of rich information there to help clinicians feel more comfortable in guiding the patient. In summary, I do want to share that obesity is indeed a chronic, complex disease with many, many causes, and it requires a comprehensive, compassionate care for a lifetime. The Obesity Medical Association has provided the 4 pillars for obesity treatment as a resource guide to clinicians as they partner with their patients in an unbiased and empathetic manner. And this will help them to develop a personalized obesity plan. Isn't it wonderful, Nick, that we now have, as primary care clinicians, people who are board certified in this, but also people who are interested in learning more about this topic, so we together can help more people gain healthier weights and healthier statuses. And there's a community of organizations and resources available to not only the patients, but also the clinicians. So if you're a patient who is ready to make a change for the better for your health, you have a community. If you're a primary care physician or a physician in general who is ready to learn more about how to do this, you have a community. And thank you for this podcast, because now that you have sustained this podcast, you now have an awareness that you have a community and you can make a difference in the life of the patient as well as the overall health of that individual. We hope that you have found this information helpful, and to obtain your CME credit, please visit theprimed.com and complete a short post-assessment. If you listen to this podcast on another platform, please refer to this episode description where there is a direct link to the activity page on Pri-Med.com for claiming CME credit. Thank you for listening to this Pri-Med podcast, and we hope that you'll stay tuned for our next podcast as we move more into medications. Have a wonderful day. Nick and I appreciate your presence. Bye for now.